pruritus, which is the medical term for itch caused by liver disease. Very briefly, what is understood about it, what isn't understood about it, how we currently treat it, not from a dermatology point of view, but just as a disease, as a kind of symptom of disease itself, and does this treatment work? By asking that question, I could probably guess it doesn't work very well. And then I'll very briefly touch on some recently published research around treating cholestatic pruritus. My colleague, Dr. Vinod Tagari, who's a final year PhD hepatology registrar under Professor Jones here, will be coming to speak to you quite soon, I believe. And most of that research is his, so I don't want to steal his thunder, but I'll just briefly mention it. Secondly, I'll be talking about the phototherapy pilot study in Newcastle that we've come up with, that you guys have very generously funded, about the idea. And then I also thought it'd be quite interesting to talk through the different stages of having an idea and talking about it in an office and reading papers, all the way through to the implementation of the project. So we are now at the stage where we're looking to recruit patients. It's starting this week to next week, and that whole process has really taken about 14 months. And I'll talk about some of the problems that I've faced, which aren't unique to this pilot study, and some of the solutions. And then finally, just to big everybody up in the room, myself included, talk about why Newcastle is such a fantastic place for this sort of research to happen. I'll talk about the clinical academic setup, in particular the junior clinical academic setup that I'm currently under, what's unique about it to Newcastle and what makes it so successful, and then briefly talk about why patient support and charity groups like LIVErNORTH and similar things are so important to small-scale pilot studies like the one we're trying to carry out. So firstly, what is cholestatic pruritus? So cholestasis literally means a standing still of bile. It can broadly be broken down into two categories, so extrahepatic, so outside the liver, intrahepatic, which is inside the liver. Extrahepatic mainly means kind of obstructive disease, so things like stones that block the flow of bile going through. And then intrahepatic, which basically means damage within the liver. Hepatocellular, cholangiocellular, in broad terms means cholangiocellular, is it a problem of excretion of the bile from the liver itself, or is it a damage to the liver hepatocytes themselves? Comparing cholestatic pruritus, so pruritus is just a fancy word for itching, comparing that to other types of itch and other skin conditions. So there's a diurnal variation, which means that it tends to be worse later in the evening and nighttime as opposed to the morning. It's generalized, not localized. So if we compare itch from liver disease compared to, say, eczema, eczema tends to be kind of in the flexors of the elbows or behind the knees, in behind the neck. But in cholestatic pruritus in general, it tends to be the whole body. It varies in severity for different diseases and in the lifespans of the disease. So what that means is liver disease like viral hepatitis or non-alcoholic fatty liver disease or alcoholic liver disease doesn't tend to be that itchy, whereas other liver diseases like primary biliary cholangitis, primary sclerosing cholangitis, intrahepatic cholestasis of pregnancy, these are much itchier conditions. And again, the lifespan of the disease, it tends to be in the early to moderate stages of these itchy conditions, of these liver conditions, when the itch is really bad. So towards the later stages of primary biliary cholangitis, for example, the itch actually might not be as bad as, say, 3 or 4 years after diagnosis. There's been many mechanisms proposed, and paritogens, which is basically a fancy word for compounds that cause itch, causing itch in liver disease, but there isn't really any accepted mechanisms for how this happens at the moment. Indeed, people have been thinking about the causes of itch in liver disease for an incredibly long time. This quote is from about 2,000 years ago, Pruritus in jaundice patients is caused by prickly bilious particles. So this is by a physician in the 1st century AD. And it could be fairly argued that our knowledge of it hasn't really improved in 2,000 years. So I thought I'd briefly talk about a couple of the different molecules that have been researched in the past, and a few of them that we're looking at in this study. So I'll first talk about histamine. So antihistamines are kind of medications that people get to treat itch or hay fever, for allergy medications, and histamine is thought of as a very causative puritogen in conditions like eczema. The levels of histamine are raised in patients with liver disease, and bile salts, which are also raised in liver disease, can actually activate the releasing of histamine kind of in experimental studies. The problem with us thinking that histamine is the main causative puritogen in cholestatic pruritus is that all the other conditions where we know histamine is the cause, the itching doesn't present the same. So as I mentioned earlier, we speak about eczema. There's a large amount of inflammation, sorry, and kind of redness associated with the itchy sensation, which we don't tend to see, at least at the start of a cholestatic pruritic process. It can sometimes be quite hard to know. Indeed, itch as a general concept isn't really very well understood, even in conditions like eczema. But it can be sometimes quite hard to know what comes first. Is it the inflammation or the itch? Does the scratching itself actually cause an inflammatory process, or is the inflammatory process causing the itch? But the fact that the picture in cholestatic liver disease compared to more cutaneous or skin type of itching looks so different suggests that this isn't the main cause of itch in cholestatic disease. So serotonin is another compound that's it's a neurotransmitter. It's seen in the brain, but it's also seen in the skin. There are some medications that are used to treat itch in cholestatic disease, such as sertraline or ondansetron, which have effects on serotonin, various types of serotonin receptors. But ondansetron is a blocker, if you will, of serotonin receptors, and sertraline is a kind of enhances the activity of serotonin at the receptor level. So it has these two drugs both treat itch, but they both kind of have opposite effects. So we think that serotonin is probably more likely to have a modulatory effect rather than a causative effect for the itch in cholestatic liver disease. Endogenous opioids for a long time were thought as one of the main causative agents. The levels are raised in cholestatic liver disease. Medication like naltrexone and naloxone, which are used in the later stages of treatment for itch in cholestatic disease, are opioid blockers, opioid antagonists. And the levels are raised in liver disease, and it's thought that the liver is the source of this raised level. And exogenous opioids, so giving people opioids as pain relief, for example, causes itch in itself. The problem with making it the main cause of itch in cholestatic disease is really down to the fact that although it is raised in liver disease compared to somebody without liver disease, there isn't a correlation between how high it is and how bad the itch is. So if, for example, we say that somebody without liver disease has an opioid level of 1, and patient A with PBC has an opioid level of 5, and patient B has an opioid level of 9, patient A might actually be much more itchy than the person who's got a level of 9. So although we know that it's raised in liver disease, there isn't a correlation with the intensity of the itch and the level of endogenous opioids. Opioids also aren't raised in intrahepatic cholestasis of pregnancy, which is a classically very itchy condition. So we don't think that opioids are the main cause. We'll move on to bile salts. So bile salts are still, Professor Jones here and myself and lots of other people think that this has to play a big factor in cholestatic pruritus. The levels are raised in people with liver disease compared to healthy controls. The levels go down when, for the first line treatment for cholestatic itch, so cholestyramine, which is the first line treatment for itch, binds to bile salt in the gut and increases excretion. That can treat pruritus very well. Other treatments that we've used also reduce the level of bile salts, and that correlates well with a reduction in itch. But the picture isn't really complete, and it's for a similar reason to the endogenous opioids. So although they are raised as a whole in people with liver disease, it isn't the case that as the levels get higher and higher, the itch gets worse and worse. Indeed, towards the end of, or say the later stages of disease such as primary biliary cholangitis, when the itch has, in most cases, has improved, this is actually when the bile cell levels are at their highest. So we don't quite have the complete picture of explaining why bile salts would cause itch. The last thing we'll move on to, which is kind of a more recent discovery, mainly from a team in the Netherlands and Germany, is LPA and autotaxin. So LPA stands for lysophosphoric acid, I think, and autotaxin is an enzyme that produces LPA. This team from Germany have found that in contrast to opioids and bile salts, the levels of autotaxin, the levels of activity of autotaxin correlate very, very well with the intensity of itch. They're raised in lots of other conditions as well, outside of liver disease. But there is a correlation both with the intensity of itch and the levels of autotaxin. And we also see a reduction in levels of autotaxin with successful treatment of itch. The problem with the LPA autotaxin stuff is, one, there hasn't really been enough research on it, and two, there isn't really a good mechanism for explaining why it causes itch. It seems at the moment to be not much more than just a marker. So it's not something that we can easily target to create a new treatment, because nobody's really sure why it's correlating so closely with the itch. There was a paper published very recently looking at autotaxin signaling with different steroids. So a bile salt has the same structure as a steroid. The paper was very, very complicated, but they were trying to suggest that because autotaxin and bile salts can perhaps combine in particular ways, that this could potentially explain or describe the union of a bile salt theory of explaining itch and an autotaxin theory of explaining itch. I just wanted to put in at the end there that the UDCA, which is the main treatment for primary biliary cholangitis, and obeticholic acid, which has recently been licensed as a treatment, can both themselves actually cause itch. And again, nobody really knows why they do that. So it's obviously a very complicated area. I thought I'd move very briefly on to talking about treatment. So the first 4 points here, cholestyramine, rifampicin, opioids and antagonists and SSRIs, that's kind of first option, second option, third option, fourth option. And as we go further down that list, the efficacy of the drugs tends to decrease. So cholestyramine is, as I mentioned earlier, is a bile acid sequestrant. So it binds to the bile acids and bile salts in the gut and causes increased excretion. I've never tasted it myself, but I've heard it can be absolutely disgusting and can cause quite bad constipation. So I think it's not a very well tolerated treatment, and also is not always necessarily very effective. Rifampicin, again, as an antibiotic, is a very, very potent drug, has pretty bad side effects. You require a lot of monitoring for your liver function tests, and it tends to only work for about 2 years if it works at all. These two treatments have been used for quite a long time before the the advent of evidence-based medicine, and so there isn't actually a ginormous amount of evidence that they work apart from kind of clinical experience and patients reporting that it works for them. After we've kind of failed those two, we're moving on to opioid antagonists. So naltrexone, I think, is the main one. Again, the efficacy of this in terms of how well it works for patients is quite variable. How long it works for can be quite variable, and particularly when people start it, it can cause kind of pain and confusion, so it's not a particularly nice drug to be on for a long time. SSRI, so that stands for, sertraline is an SSRI. There's limited evidence that it works. Nobody's really sure why it works. It's used for lots of other conditions, but once we're getting down to this kind of fourth line treatment, we're really clutching at straws. If the itch is kind of intractable and the person is suffering greatly, then we can do more invasive procedures, so things like extracorporeal albumin dialysis or plasmapheresis, or indeed Vinod recently did a paper on nasability drainage, and these things can work really, really well in treating itch, but they're very invasive. You can't have these procedures done at home. They each carry their own risk of doing a procedure, so they're not really necessarily a viable long-term option from somebody suffering from itch. Eventually, when we're getting a bit further down the line, a liver transplant can, in and of itself, the itch can be in and of itself an indication for a liver transplant, but I'm sure most people in the room here will know much more than me about how difficult these can be to come by and all the risks and complications associated with that. And finally, I thought we'd just very briefly mention another paper that I believe Vinod will come and speak to you about in May or June. He's recently done a trial which was published in the Lancet, which is incredibly prestigious, looking at IBAT inhibitor, which is an ileal bile acid transport inhibitor, which basically improves the excretion of bile acids, and that's still at a kind of clinical trial phase, but early results are really, really promising, but I don't want to talk any more about that. So kind of in conclusion, sorry, this is just the European Association of Study of the Liver's kind of algorithm for going through the different treatments. So you can see in the middle the cholestyramine, rifampicin, sertraline, and naltrexone. This is kind of the standard pathway that's followed at the moment. So in conclusion, cholestatic disease is difficult to understand and it's very difficult to treat. And moving on to our project that we're going to trial here, hopefully starting next week, we're hoping to improve the understanding of cholestatic pruritus and hopefully offer a viable alternative to treatment once those first few lines of treatment have failed. So the pilot study is using phototherapy twice a week for 12 weeks in a small select group of patients and seeing how they respond to phototherapy from their itch. So I'm sure that many of you are aware Newcastle itself is a very big centre for primary biliary cholangitis research, but it's also a very big centre for dermatology and phototherapy research. And there has been 5 to 10 patients over the last few years that have been sent to phototherapy from hepatology as a sort of, nothing else is working, let's see how this goes. And some of them have reported fantastic response, complete reduction of itch for a couple of months or longer after a couple of sessions of phototherapy.